I thank Dr. Srikanth for this combined effort. That's all I can tell you. This is called electrophysiologic test. And many of us know when you encounter a case sheet or whatever thing, the chart of electro ERG, we find it difficult. What is there? We do not know what is happening there. That's why I wanted to take this instruction course to tell you the basics. How to read a ERG, how to read a EOG. These are the basic things you are supposed to know. What is happening, ERG? Everyone knows that we have got rhodopsin in our rods, cones, everywhere. This rhodopsin, when it exposed to dark, or when it exposed to light, what happens now? It breaks into so many steps are there, and then divided into we got that is called transretinol aldehyde, then opsin. Opsin is a part of the rhodopsin. These two things have to combine again. Actually, what is there in rhodopsin cycle? Rhodopsin, it is nothing but the cis form of retinaldehyde, cis form. Whereas once you get exposed to dark, instead of this light, what happens now in light, they break into trans-retinaldehyde, transform. Now the transform again, when you go to dark, getting converted into cis form, then again the regeneration of rhodopsin. This is what's happening. For this regeneration, we require what is called vitamin A. That's why vitamin A is a must for the regeneration of rhodopsin. If it is not there, naturally we get what now? Night blindness patients. That's why the patient takes more time to get adapted for in a case of vitamin A deficiency. Stick on one thing called chicken eyes. Chicken eyes, you don't know. Anyone, I tell you, what is chicken eye? Chicken eye means the vitamin A deficiency, patient may develop night blindness. That fellow is supposed to have a chicken eye. You know the reason? Chicken is night blind. That's why you got a night blindness. Chicken eyes. This is what the life cycle, that's a rhodopsin cycle I told you. When the light falls, it divides into what? It breaks now into opsin and the transretinal. In between, I got so many steps like beta rhodopsin, lumirhodopsin, meta rhodopsin, meta 1, meta 2, like this. Then transform. Then we have got a cis form, again coming back to rhodopsin. This is what the normal cycle we are supposed to know. All these things cycle mainly taking place where? In the outer segments of rods and as well as the pigment epithelium. Pigment epithelium, the basic responsible for this converting to rhodopsin. So pigment epithelium is a must for us. RP is the principal site for the cis-retinal region. I told you what? The trans-retinaldehyde has to be converted into cis form, then only they can regenerate rhodopsin. So this form conversion of trans to cis form occurs in the pigment epithelium. Now, to know all these things, we have got when a light is, or you imagine now, you keep the patient in dark, what's happening now? The rhodopsin is created. Rhodopsin is generated. When you expose him to light, what happens now? The rhodopsin is a brick. This is what's happening now. Now these formations, when you put a light or whatever thing is there, what's happening when the light is falling on the retina, rods and cones are getting stimulated, they produce what is called action potentials. These action potentials, they are going to record as ERG. That's why when you ask, ERG is what for? ERG is mainly to assess the function of rods and cones. What about the EOG? The Srikanth is going to talk about EOG. EOG is mainly to assess the function of pigment epithelium. These are basic things. And one more thing is that if you might have heard about visual evoked potentials. These visual evoked potentials are mainly for assessing the function of ganglion cells and above, optic nerve, visual pathway. These are basic three electrophysiological tests. At least we should know. At least you should know how to read also. That's enough. Next we have got, I told you now what's happening here. See now. This is what I told you now retina function. Retina, can you see here? I told now here EOG. EOG represents the RP functions. Then I told you about ERG, everything. They're all telling about the function of rods and cones. Now in ERG, what happens now? How to proceed now? First I will do what? I will keep the patient in dark for 30 minutes. For 30 minutes, I keep the patient in dark. And the pupil is dilated. You have to dilate the pupil. Now, when you dilate the pupil, the patient is in dark for 30 minutes. What's happening now? The rods, they are highly sensitive. Because after 12 minutes of darkness, the cone rod breakup time comes. Afterwards, the cones may not respond. Whereas the rods becoming highly sensitive. By the time 25 minutes or 30 minutes, the rods are highly sensitive. Now we keep him dark now. Pupil is dilated. Now I will put what? A blue light. Blue light, we have got a short wavelength light. The blue light can stimulate only the rods. The cones may not be. So that's why when you stimulate a blue light, we are going to put a blue light, the rods are getting stimulated and they are going to record an impulse, that's action point generated, that is called rod response. Next, what I will do now, at the same patient now, I put a white light or a red light. Now both rods and cones are going to be stimulated. That is going to give a response called combined response. That means I got both rods and cones response. These are two things you are going to record in ERG in a dark adapted eye. One more thing is there, I tell you, but ERG, we got a classical waves, A wave, B wave, so many things. In the B wave, never forget this, B wave, you got an oscillatory potentials. That is called OPs. Oscillatory potentials are also recorded in dark adapted eye. Oscillatory potentials are normal phenomena, normal. These OPs are what are they? They are all nothing but the intercurrent in the inner plexiform layer, inner nuclear layer. They are getting proper blood supply or not. If you have got a proper blood supply there, the oscillatory potentials are normally present. If it is absent, I know some problem is going on. What's the use of here when you do this? Imagine a case of diabetes. Diabetic patients, when you see the fundus, 15 years of diabetes, you are seeing fundus, nothing is there. Now if you do ERG, if you see these oscillatory potentials deranged, normally present, you would deranged, what happens now? You know something is going on in the inner layer. Some schema is going on in the inner nuclear layers. Understand now? That means you can suspect this fellow in future may develop some problems. Like that, the importance of ERG is like this. I'll show you here. What is ERG? I told you now. It's a mass response. I put a blue light. I put a white light. Whatever thing is the white flash. What's happening now? This light falls in any part of the retina. Need not be macula alone. It can any part of the retina. You can have an impulse. That's why what? ERG, you cannot tell which region you have, which area you have stimulated. It's very difficult. So it's called the mass response. Any part of the retina is functioning. Suppose macula is not working. I see the periphery is working. I can get ERG. That means you cannot pinpoint where the lesion is. That's the importance of your ERG. Understand now? To overcome that, we have got some specialized ERGs like a foveal ERG. We can have a pattern ERG. Like so many things are there. That means you have to do, if you want to see only the function of macula, you have to do this type of ERGs. But normal ERG, what we are using is, you cannot pinpoint where the area is, which area is working or not is very difficult. You can tell some mass response, part of retina is working, that's all. You cannot tell which area. How to record? Record means what I already told you. You have to, first I told you have to, pupil dilated, dark room. What I will have, what I will do? After 30 minutes of darkness, I put a blue light, a red light, finished. Then take him to light, you keep him for 10 to 15 minutes, light adapted eye, I put a white flash. White flash, that means what? It's a flashlight only. That means I'm going to record what now? Because in light, the rods are bleached. The rods are bleached now. Now the cones are going to respond. That means I'm going to record a cone response. The same way, suppose this white flash, not only your cones, mainly cones agreed, rods also may be responding, we do not know. So to overcome that, I use what is called a flickering light, rates of 30 hertz per seconds. There's a flickering rate, 30. They've got some machines around 30 hertz, it's called hertz, H-E-R-T-Z. So hertz flickering rate is there. You apply that rate, 30 hertz, only the cones will respond. That means what? A light adapted eye, 30 hertz flickering light, only the cones are going to be responding, whereas rods are not going to respond. See, rods can respond up to a maximum of 12 hertz. 12 hertz flickering rate only. Whereas more than that, the cones are going to respond. That means what? When you keep a patient in light, I put a 30 hertz flickering light, I am going to record only cone response. See the beauty now? Light adapted eye, 30 flickering now, cones. By chance, imagine now that the 30 hertz flickering is not working. The cone does not responding. Whereas the dark adapted blue light rods are working. I know the problem is somewhere in cone dystrophies. Cone problem is there. Suppose the cone is not responding. The dark adapted eye rod is responding. I understand now. Cone problems. Suppose cones are working, rods are not working. I know rod dystrophies. Both are not working. I know it's a rod cone dystrophy like retinitis pigmentosa. That is what the basic things. So always remember, you can easily differentiate the ERG whether it's a rod problem or a cone problem or a combined problem by using all these modalities. This is what ERG states. When you do this, you know what happens now. Here, there are 3 electrodes. Pupil dilate and never forget. One on the cornea, contact lens. That is what active, whatever thing positive. One more thing is the forehead they have to keep. On the forehead, some passive, something negative or something, negative pole. One thing on the earlobe, that's ground electrodes. There are 3 electrodes. One on the cornea, positive. One on the, that's called active electrodes. One on the forehead, negative. Then on the earlobe, ground electrodes. That means a good record. I can have either contact lens or I can have some gold foils. I can keep it in the phonics. I can keep it in the lid. So I can have lid electrodes also available. No need to touch the cornea. So that may be useful for children because normally you have to put a contact lens, something difficult. So children is better for us to use a gold foil or something like that. The electrodes kept in the lids. You can record. People dilated, I told you, active reference electrodes, ground electrodes, everything. Active electrodes, I told you, positive, remember, hot contact lenses. At least you know one name called Briandalan. Then filament types, they are kept in the lower lid, gold foils. These are the ways of recording. These are all active electrodes. Whereas reference, what now? Silver nitrate made up of serves a negative pole that is kept on the forehead. Whereas ground electrode, that is the earlobes. This is the way you can see now here. This is the corneal electrodes. Of course, here they would have got forehead electrodes. Of course, here other side they have kept. Recording protocol, I told you, 30 minutes of pupil dilatation now, dark room, red rod response, combined response. Or what is rod response? I told you blue light. What is combined response? I told you white light. Oscillator potentials, that is seen where the ascending elbow B wave. That's what you're going to record. 30 minutes, then light adaptations, single flash cone. That was single flash. I told you single flash cone may be responding, but in that part, a small amount of rod also may be responding. That's why we have to have a separate 30 hertz flickering light to record only the cones. That illumination or the stimulus is called a bowl-like thing. You might have heard about Humphrey metal like this bowl. Similar bowl is called Gansfeld. So Gansfeld bowl give a uniform illumination for the patient. Now 3 waves are created. Classically, never forget, it's in a combined response. When a rod response is there, only few waves. We don't have a typical ERG finding will not be there in rod response. A wave may or may not be like that. We can't differentiate which wave and all. Whereas in a combined response, both rods and cones are responding. When you have a dark adapted eye, when you put a white flash, you get a classical wave records of ERG. This is what is called A wave. Can you see this A wave? This is the A wave. A wave is a negative wave. This is the baseline. This is the baseline. A wave is a negative wave. Now we see it's going B wave, going up. See now you can see the oscillations. These are oscillations normally. The B wave can go up and then come down again. These are basic 2 things you are going to see now in clinical practice. Sometimes in academic practice, I can tell you, sometimes I can have a C wave. C wave may come this after the B wave. After this B wave, some wave may come like this. That is called C wave. When I see a C wave, that means your pigment epithelium is working properly. That's all. Sometimes I can have in academic again, I can go and have one more wave, D wave. After C, one more D wave, positive come. That is nothing but I put the light, switch off the light, on live, switch on, off. I'm going to have a response like this. That's called D wave. But these C and D are not of much useful for us clinical practice. What is most important for us? A and B. That's all. A wave, I told you now, A wave is what? Negative wave. The A wave is coming from where? Your answer is rods and cones. The so photoreceptors are responding. The action potential generated is going to via inner plexiform layers. That has to go. Naturally, the A wave is coming from rods and cones, finished. Whereas the B wave coming from where? Once the action potential generated from rods and cones, they are traveling. It has to go to my brain. So they're traveling to my inner plexiform layer or inner nuclear layer. We can have a response. This inner nuclear layer, you might have heard about Muller cells. Muller fibers, they're all nothing but nutritive function, supportive function. Muller cells extending from internal to external membranes. These Muller cells also take part in the formation of B wave. That's why B wave is coming from where means bipolar cells are inner nuclear layer and Muller cells are both are working properly. That's all. When you have a problem in this, I already told you, the oscillator potentials are what? Is a rippling current by inner plexiform. That means inner plexiform or the inner nuclei, they are working properly. If they are having some oscillator potentials are absent, means inner layer is suffering. That's all. Hypoxia is going on. It's a classical thing in diabetic patients. If you want to know, you do ERG in the early stages, you can at least come to a conclusion. Yes, this fellow in future may develop problem. Rather, you can come to a conclusion. That's all. Now, classical, can you see here? The blue response, this is a blue wave. See the blue response here, this is called rod wave. I told you, that is not typical waves. Only the B wave is there, agree, that's all. You see the first line, this is the rod response. Second response, you can see now, this is the A wave going down, the B wave going up, and then coming down. The B wave. Now, two things you are supposed to see. What is the amplitude of the ERG? What is the implicit time? Implicit means latency, that's all. Implicit time of ERG. What is the amplitude? Suppose I measure the amplitude of A wave from the baseline. This is the baseline. This is the baseline. From the baseline, the bottom of the A, how much milliampere, whatever thing is there here. That is, I tell you, that is amplitude of A wave. What is B wave? The bottom of the A. The bottom of the A. Understand? Bottom of the A. You got light, project, hello. Sir. Light, project. So now here you can see now, this is the A wave. Sorry, this is the rod response. Of course, there also you can have the A waves coming in this side. But A wave is not classically seen, whereas the B may be seen. Whereas the combined response, you see now here is the A wave, the going up is the B wave, and coming down. What is the amplitude? This is the baseline. From baseline to the bottom of A is the amplitude of A. The bottom of A up to maximum of B. This is the amplitude of B wave. Two things only are supposed to know. Amplitude of A and B. One more thing. Suppose I am putting a light now from here. This is the onset time. This is the light onset. I am going to put a light now. From here, the light onset, you are starting the light. From there to maximum amplitude, something is coming A wave. This time, the time taken is in milliseconds. That is the implicit time of A wave. That is a maximum amplitude wave is coming after how many milliseconds? From the light onset. Similarly, from the light onset, maximum amplitude B wave, how much is coming? That's called implicit time of B wave. These two entities what you are supposed to know when you interpret. The amplitude and implicit time of A and B. You know one thing? These things are particular laboratory differ. That's why when you get a result, they will give a result in our laboratory. A wave, amplitude so much. This patient, A wave is this. In our laboratory, implicit time is so much for A wave. This fellow's implicit time is so much. Then I can have, of course, I can see the wave and tell you that's different. But to see more perfectly, you should need a separate paper. Just like our blood sugar, in our lab they give some results. Same in number values. Similarly, the values will be there for ERG also. So this is what, and you see now below, you see now some line here, oscillations. The third thing is called oscillator potential taken exclusively from your ascending limb B wave. This is oscillator potential. Suppose it is flat. Suppose there is instead of oscillations, something is a flat. The problem is there, you know that inner nucleus is suffering. The other can easily come to a conclusion just by saying, of course, this right eye, left eye, both eyes are supposed to do. Then next is what now you have got, this is what I already told you. This is what the now, time, this is the implicit time from onset to implicit time. Then it's the amplitude. Remember all these things. These are all the records you are supposed to read in the ERG. One more thing. This is what, of course, no PG is there. If PG is there, they are common questions. If I see now ERP, ERP means what now? Early receptor potentials. Early receptor potential. What is the early receptor potential? I'll tell you. What is the early receptor potential? So, we have got, so now here, this is the A wave starting here, A wave starting here. Before, from the onset of impulse, the A wave starting. In between onset and the onset of A wave, you can have some positive waves coming up and down sometimes. That is called early receptor potential. That means between the onset of the A wave and from the impulse, I can have some waves called ERP. ERP denotes what? I already told you. Rhodopsin is there. When I put a light, the rhodopsin is going to break. I told you, lumirhodopsin, metarhodopsin, so many things are there. Now this shows what? ERP is there means, that means the beta-rhodopsin, like this. Lumirhodopsin to metarhodopsin going on normally. This cycle is going on properly, that's all. ERP denotes the conversion of lumirhodopsin to metarhodopsin is going on properly in the rhodopsin cycle. That's all. This is what importance of ERP. These are all some of the exam questions for PGs. Oscillator, I told you, oscillator potentials in the ascending limb. Can you see here? The oscillator potentials. These are all the oscillator potentials in the ascending limb. If there's something absent, actually I already told you. I told diabetic retinopathy, remember I told you, diabetic retinopathy is significantly reduced. Now, cone response. What is cone response now? I already told you now, see, light adapted eye. Light adapted, not dark, light adapted eye. That means what? The rhodopsin is bleached. I'm going to stimulate now a flash, single flash. That means single flash cone response is like this. You see now you cannot have typical waves. Only combined response, you got a classical ERG response. Whereas here is some wave, see, can I tell you some wave is that? That's all I can tell you. But it's not typical. Whereas now if I want, I have a classical uniform picture of the cones. Uniformly, so now, like this, classical same type of movements, same type of waves are seen. That is called 30 hertz. Is considered 30 hertz. That is flashlight, flickering light of 30 hertz. 30 hertz means 30 oscillations per second. Instead of that oscillating light or a fluctuating or a flickering light. Understand now? This is called typical cone response. That's what I told you. If this is absent, the rod response was there, that means cone dystrophy. You understood now? Like that you can easily tell. I'll show you some of the things. Can you see now here? See now here. See now it's a combined response. Rod, that means what? Dark adapted. Just by seeing that I tell you, rod's maximum combined OP means oscillator potentials. If it is there, I know it's a dark adapted eye. Now the first response, rod response, nothing is seen. See now next, the combined response, nothing is seen. And you see the oscillator potentials out. That means what? This fellow, dark adapted eye is out. Yeah, there was some problem in dark adaptations. This is what you can easily come to a conclusion like this. The same way you can here. Same only here also. Can you see now? Rod maximum combined, that means dark adapted eye. By seeing this you can tell. Now it's also gone. Here also gone. Here also gone. That means what? When it wave like this, I will tell you is an extinguished. I will not tell amplitude reduced like this. I will tell you the entire waves are gone. That means I will tell you these waves are extinguished, which is a classical feature of rods and cones. Classical, maybe RP. RP patients can have like this problems. And now it's called extinguished waves. See now same way, see now same under patient. See the cone response, single flash at a cone 30 hertz. See now nothing is there. That flickering light also, the typical waves are not seen. That means the cone also gone. Previously dark adapted gone. Both rods and cones gone. That means what? It's a dark cone dystrophies. Classical RP. In RP patients at the end stage, we will have extinguished ERG. That's all you are supposed to know. Then sometimes what happens, negative ERG is what? What is a negative ERG? I tell you. See, what is negative ERG? Negative ERG means, see the A wave is already negative. A wave is already negative. The B wave is a positive wave. Now the B wave amplitude is coming down towards the baseline. That becomes negative ERG. The B wave amplitude, when it is getting reduced, is coming towards the negative side. That is called negative. Then where will you get this problem? Negative ERG. That means the B wave amplitude is not coming out. The problems are classical problems. We can have, you must be knowing, intraocular iron foreign bodies, siderosis. Then one more, retinoschisis, X-linked recessive retinoschisis, juvenile retinoschisis. That's classical thing. Then we can have siderosis. Then station night blindness, congenital station night blindness. You might have heard congenital station night blindness like albipunctatus or retinitis. You might have heard. You can purchase it. Or retinitis punctatus, albipunctatus, or Oguchi disease. You might have heard at least Oguchi disease. These are all congenital station night blindness case. They can have a typical negative ERG. One more thing is supposed to have prognosis. CRV occlusion case, ischemic type. Ischemic type is that I told you. B wave is coming from inner nuclear. I told you. That means the ischemic type of CRV. That means inner nuclear is going to be affected. So I can have the B wave amplitude is coming down. Here, you should know the B wave amplitude you take. Now A wave amplitude you take. Divide them. It's a ratio. B amplitude by A amplitude is a negative AC ratio. If it is normal, it should be more than 1 because B is always a positive. In this case of CRV occlusion ischemic type, the B wave amplitude is coming down. Its ratio is altered. Now you know the problem if the patient is having ischemic type, that it will develop in future the problems like this. This is called B by A amplitude is reduced. Remember I told you? Negative ERG, siderosis, other two things, I don't know, not responsible. Most important was station night blindness, X-linked retinoschisis, and siderosis. These are the 3 things you are supposed to know. Negative ERG, that's the amplitude of the B wave is coming down, that's all. It is called negative ERG. Sometimes I can have negative ERG. You know what is negative? The A wave, negative, B wave, also amplitude. I told you, first negative ERG, that's all. It's called negative, both are coming towards the negative side. It's called negative. One more, very rarely they will tell you, negative positive. That means what? The A wave is having, negative means A wave is more. But the B wave is normal. See, the B wave is normal, but it's called negative positive. It's called negative positive, but it's a normal affair. It's a normal affair. In many individuals, you can have a picture like this. The A wave amplitude may be increased. The B wave may be normal. Don't take it seriously. It's something normal only. It's normal affair. This is called pattern ERG. I told you pattern means what? The change of patterns, like a checkerboard. If we keep on putting on, the pattern is going to stimulate where? The pattern, if you want to see your macula only can see. So when the macula is stimulated with pattern ERG, what they are going to record is a macula area function. That's why the pattern ERG is very useful to differentiate a problem is because of optic nerve problem or a macula problem. In pattern ERG, the macula problem, the problem will definitely manifest. Whereas optic neuritis patient may not develop problems. This is what the use of pattern ERG. That's why I told you, ERG is a mass response. ERG is a mass response. You cannot pinpoint the area. But if you want to pinpoint the macula and all, you need a separate ERG called pattern ERG, foveal ERG like this. I hope you have understood something about ERG. Then Srikanth, he is going to give a lecture on EOG.
Of RP, if there is lens cataract, is it possible?
Yes. Yes. You are not going to put a pattern is something difficult. Whereas you can put a light and see.
Well, in lens cataract.
Whatever cataract, some light will reach, definitely. Multifocal ERG, different. That's all. You have to record everything. You have to superimpose the retina. That's all. And you can tell the macula area also functioning, but the ERG response is normal. Multifocal ERG also useful for finding out the macula functions.
So when do we advise someone?
When you have suspecting the problem is you got the macula or something. That's why mainly the macula function I cannot tell. So naturally, when I have a multifocal, I can see the entire retina image. Then only you can tell the function of each layer is affected, which area is affected. Like that you can tell multifocals. That's what.
So how do we clinically, when I am advising a patient for ERG, which ERG will I advise?
Normal ERG, if you write, they will do all those things. If you want to have a foveal ERG, you can write multifocal. Nothing wrong. If you suspect some problem is there in the fovea, macula is not working, I can do a pattern ERG or multifocal.
Which one is a great pattern or multifocal? I think
But normally they don't do multifocal, because normally ERG is only they are doing. Many institutes you have seen now, many institutes they are having only normal ERG. Only multifocal, specifically they ask, we want to know a function of a macula is working. So
Multifocal is not going to give the information of normal ERG.
normally same ERG picture only is superimposed on the retina. So I told you ERG coming from anywhere part of the retina. So I can take a multifocal ERG, means what? Response of each area is going to be superimposed in the picture. Retina diagram, retina picture is going to be superimposed. Then only you know which areas, suppose that area's amplitude is less, means I know this area is not working. Want anything? Dr. Srikanth, professor of ophthalmology in Mahatma Medical College, Pondicherry. Is my old student, friend, philosopher, everything is there.
Thank you, sir, for introduction. He is my mentor, and I owe everything what little I know to sir only. For many years, he has been trying to teach me, put something into my head. So after seeing ERG, we come to another mass response. It is another electrophysiological test that measures the resting potential between the cornea and the Brooks membrane during the light adapted and also in the fully dark adapted state. So that basically we are recording the positive and negative potentials between the anterior and posterior part. So recording is by placing an electrodes at the outer and canthus of the eye and one reference electrode in the center of the forehead. So the eye's pupil has to be dilated, skin electrodes are placed, and ground electrodes are placed in the forehead. This is how it is done, and the patient is asked to move the eyes either way, towards the right and also on the left. So when the eye is moving towards the outer side, it becomes positive for on that side and negative to the right side. For example, he is moving the eyes towards the left. So the electrodes on the right will show negative potential, and that on the left, toward the eye towards which it is moving, will show a positive potential. So this basic difference we are recording and saying whether the response is, the ratio is normal or abnormal. So basically this again detects the mass response only. So the dark adapted phase has to be there. The eye is dark adapted for minimum 15 minutes. Then again the recordings are done, and again light is exposed to light, and in the photopic condition again the recordings are done. So this is how it is done. So you measure the amplitude, you measure the time latency between these recordings, and that is given in a chart. So this is what I told. The closer electrode to the cornea becomes positive, and electrodes in the opposite side becomes negative. So here the care has to be taken. Two things are important. One is dilatation of the pupil. Second is the dark adapted state, whether it is properly done or not. And while moving, the eyes only should move, not the head. So you can see in this picture how the electrodes are kept and how the eyes are moved in each direction. So we see what is the light peak and the dark trough. Light peak is the one which is the maximum peak of the waves recorded at during the light exposed phase. So this results from the movement of intracellular calcium released from the endoplasmic reticulum. So this patient is exposed to light, and peak amplitude is reached by 7 to 12 minutes. That is known as a light peak. So here the picture shows pointer. So here you can see. Here you can see this is light on phase, 15 minutes, then lights off and light on. You can see the light is on. This is movement when the patient is looking towards the right, then movement when the eyes are looking towards the left. Like that it goes on, and the light peak is reached say by 10 to 12 minutes. Same way when the lights are off, after 15 minutes of dark adaptation, you see this, eyes are moving out to the right, looking to the left, like that. So this is the dark trough. This also comes say by 10 to 12 minutes. So this ratio is what is famously called as the Arden ratio. Earlier it was called as the Arden ratio. Now these recent standards, we just measure where is the light peak and amplitude and time to start. All these are taken. So variations can happen if the pupil size is not regular on both the eyes. Deviation from the standard protocol can result in variations of these recordings. So again, this is again a mass response which you will get when the RP is photoreceptor complex is affected. So this is not you cannot differentiate whether this is due to this or that. So this is you can see the difference where ERG may be normal, but the EOG may be abnormal. So this is what you can see in this. So reduced thing, EOG, ERG is normal. Use in this macular dystrophy, best macular dystrophy. Even before the classical picture is seen, you can pick it up by this. Usually these tests are done when you don't find anything really grossly abnormal, but the vision doesn't improve. So these are the tests where it is not a routine test. When we have difficulty in diagnosis, then these things are used. So autosomal recessive reduced light rise is seen. So here mildly reduced Arden cone response. So here it is normal. Here it is normal. So like that, this is how these are used to differentiate between the place of the lesion and the type of dystrophy. So these are all few diseases where there is an abnormal EOG with normal ERG seen in Best disease, fundus flavimaculatus, as sir told, also in chloroquine retinopathy. So abnormal EOG you can see in Best disease, Stargardt's disease, retinitis pigmentosa, chloroquine toxicity, siderosis bulbi, and in vitamin A deficiency there may be a flat EOG, and CR vivo ischemic there will be abnormal light peak. So these are the things which is seen. You can see the normal EOG with dark phase at 12 minutes and the peak phase again at 10 to 12 minutes or sometimes 8 to 12 minutes, and you can see this reduced dark phase as well as the light phase. So here again hydrochloroquine toxicity, you see the value, Arden value is 1.48, 1.36. Whatever it is below normal, that is 1.8, is considered as something abnormal. So here again a normal subject, dark phase and light phase. Here it is reduced, seen in cases of retinitis pigmentosa. The light phase again is decreased. You can see here. So special thanks to my mentor who had included me in this instruction course. Thank you so much, sir. Any doubts? I'll be.
And these slides. Now, how will you make out that the light phase in the
You have to.
dark phase? How do you in
This
these
one?
charts?
This one. This one.
Yeah. How can you make out the dark phase?
This is dark phase. Wave is not there, but represented in a different way. This is the normal one, but represented in a different way.
This, how do we make out the
Here, both the things, both in the dark as well as light phase, both it is depressed.
She is asking for value.
Yeah, value. That value is not. Yeah, that it is not in a wave pattern. That's what I think you mean. Instead, it is represented in this way, as dots.
yeah, this I can make out should be like this. It's
Yeah, this is like this.
we make out that the
Yes.
dark is up down.
So the compare it with this, it is abnormal. That's all. Here you can see the Arden ratio when it is given, then you will be able to make out that it is an abnormal thing.
Actually, we try to explain something, and ERG and EOG, and which normally we don't see. Most of the patients, some institutes, they can have ERG machine, may not be working. It will be lying somewhere, and some institute will be working. And now, actually, I started learning ERG when I was in RIO Chennai, Regional Institute of Chennai. There also ERG machine was not working. So we used to refer the patients to know something. I used to refer the patients to Shankar Nethralaya there. Then I used to get a report. Then only came to know ERG is like that. So many things are there. We can easily interpret so many things in ERG. Now, basically, what you're supposed to know is, if you want to know the functions of rods and cones, ERG is better. Functions of pigment epithelium, if you want to know, EOG is better. If you want to know the optic nerve and other areas, VGP is better. VGP also same thing only. We get our recordings. One is on the forehead. Is called Z point, the central point of the forehead, central point of occiput, and then we got a earlobe reference. So one is positive, one is negative, one is zero. It's called same VGP. Just like EEG, the record. They put what they do, record here one central point forehead, occipital lobe one forehead. This is what a normal VGP. When you apply flash is going to fall on your retina. The impulse is going to be is going to my brain, occipital lobe area. It's going to be recorded. Now they will find how many milliseconds it takes for the maximum amplitude to come from this flash. They will have values and all. They will have waves. That's called positive 100, P100, or positive 135. Like that, they give numbers. So P100 means what? The positive wave. N75 means the negative wave. The maximum N75, after 75 milliseconds, the negative wave has to be maximum. After 100 milliseconds, the positive wave has to be maximum. They have given everything. So the positive P100 is there. If it is, suppose the positive is coming after 150 milliseconds, that means the problem is prolongations. Some conduction pathways problem is there.
Latency.
Latency. The time taken for the maximum amplitude. The P100 means a latency. The P100 wave, normally after so many milliseconds, it comes. Now, if it is 125, that means what? 100 to 120 is prolonged. That means the time taken for P100 to come is 125. That means prolonged latency.
What is the reference value?
They will give values. The paper itself will be there. P100, the number will be there. P100.
But what values will be taken as normal?
Normally, after 100 to 120 milliseconds. 100, because your impulse, I'm standing in front of you, I am falling in your retina, and I'm going to reach your occipital lobe. It takes minimum 124 milliseconds. 124 milliseconds, that's the normal time from ganglion cell to your occipital lobe area. That is what you are going to record. But actually, it's maybe 100, 125, so many things are there. Just know if it is prolonged, latency is prolonged, conduction problem. Now I know amplitude. Amplitude from baseline you are going to measure. The amplitude reduced means what? Ischemic problem. That's all. The pathway is suffering. The ischemic problem is there. It's not allowing the amplitude based on the function of that area. If the function is not working because of ischemia, naturally the amplitude reduced. So
We often give a report saying probably of demyelinating.
Latency is prolonged. Probably deblooding problems. Amplitude reduced. Maybe a case of that area occipital problem is there. Maybe a tumor. Maybe ischemia. Later you can tell.
So that means the p-value will increase. Instead of 100,
P100, the P100 value
that will
increase.
What is telling them it is the d
If it is incremental problems, it's not ignorant, classical. If it is P100, amplitude is about something is there, is coming down. That means some ischemia is going on in that area, in this official pathway, and it may be anywhere.
300 would also increase say in a glaucomatous activity. We think that affects.
No. P100 ischemic problem, it will be decreased. It cannot increase.
That's unfortunately.
Latency can be prolonged means it's a myelin sheath problem. It's mainly the myelin sheath is the conducting element. Myelin sheath, demyelinating problems, the myelin sheath is a conducting element. It's not the axons. Axons are all just taking for your functions, that's all, mitochondrial transmission, all. The myelin sheath is responsible for conduction. That's why you got a RAPD. Why demyelinating problems? The conduction light is delayed. RAPD is because of demyelinations. It's not because axon means your visual problem will be, the visual acuity may be reduced.
Is there a chance that a test may be inaccurate for the way it has been done? That we need to see a quality score or something?
The computer itself is a message, impression is good. The computer, they've got machines. It will give you correctly.
So there are some cases there is confusion between optic atrophy. What is the cause of optic, also whether it is demyelinating disease or glaucoma. So there must be some confusion. So how to delineate such cases with the
Glaucoma is an ischemic problem. Definitely amplitude be reduced. See, if you want to know the full area of the visual pathway, you have got a multifocal EEG. They will have electrodes here, one electrode, 3 electrodes in the occipital lobe, the parietal of some area, and frontal lobe. Everywhere the electrodes will be there. That means they have to find out the entire visual pathway. What VEP are going to see maximum up to chiasma. That's all. If you want to see the tract and all, you have to go in for multifocal. Multifocal VEP is there. Then only can tell you, albinism patient is there. Albinism patient, oculocutaneous. They will have more amount of crossing fibers. That you can easily find out multifocal.
Beyond chiasma, then we have to mention
Multifocal. If you want to know, I want to know my LGB, whether it's working or not, I want to know this multifocal. Because your VEP normally maximum chiasma, that's all. Maximum. Even optic only maximum, we can tell you. Whereas chiasma and above also something you need a different VEPs, multifocal.
So usual VEP is up to chiasma.
Ordinary VEP.
Ordinary VEP.
Maybe maximum up to, that's all. Because chiasma also very difficult to me, because crossing is there, they will find it difficult. So, understand, this is what, and one more very nice inference, we got a pattern VEP is there, not light, like a ERG pattern, no? I can tell you the macular functions and all. This pattern VEP, suppose I put in our eye, it takes about 100 milliseconds to reach, I get a maximum amplitude. Suppose normal, you are a minus or something. I put without glasses, I put a light. I have some impulse. Now I am not getting a maximum amplitude. Now I put a glass. Now it's going to be focused on the macula. I get a maximum amplitude. Now I can indirectly find out your power as well as whether you are myope or hypermetrope. Even your refractive status also you can find out the VEP. That's the beauty of VEP. But mainly pattern VEP, not flash.
Usually what we do is flash VEP.
Normal, all VEPs you do. Pattern VEP, that is called on-off, so many things are there. Checkerboard patterns, pattern reversal. Then we got ordinary flash VEPs. Then we got on-off phenomena, something like that. We got different.
Pattern also gives some flash light.
Flash means checkerboard. Checkerboard is there, no? Like a chessboard. Black is there. Black for 2 seconds. And that black will become white. Again, that's called pattern reversal. Pattern reversal VEP.
Like ERG.
ERG only. Pattern reversal VEP.
The pattern reversal will give us more information.
More information about the macula and all, definitely. Because with macula only you can tell you this pattern.
Pattern VEP.
Pattern VEP itself, pattern reversal only they put. They will not only a pattern, they will keep on reverse it.
That will give us
More information about your macula, that conducting pathways, that's all. Any doubts, sir? No? Are you okay? You're able to follow us?
Yes.
Thank you. Thank you very much.